Great. Well, thank you very much for the invitation. This is a bit impersonal from my side, and I apologize for that. But I thank very much the opportunity to speak with you today. And I understand the schedule pressures, and also want to thank the AV folks who have worked hard to get this all set up appropriately. Let me go through a couple of slides here, but I also want to make sure that we leave time at the end to talk openly with any questions and comments that you may have as well. So just to back up a step, my name is Jennifer Clawson. I've been working in healthcare for roughly 20 years, and about half of that time working on the topic of value-based healthcare. I'm actually based in our BCG Madrid office, but work more outside of Spain than inside of Spain. What I wanted to do today was, first of all, start with a story about a patient, recognizing the value and the reason why we're all here today. This is a little girl who's suffering from cystic fibrosis, and if she had been born when I was born, she wouldn't have lived roughly past the age of 5. But it's thanks to some pioneering folks who decided to measure the outcomes that are most important for cystic fibrosis patients, and to do so systematically, that she and others like her have a much longer life expectancy and a much fuller, richer life today than they would have 30, 40, 50 years ago. And so this is the tribute to what gets measured gets done, and a couple of key clinicians who were working in the cystic fibrosis space back in the 1960s and 70s were asking themselves, if we're not measuring the outcomes, how can we actually tell what we're doing for patients? How can we actually make sure that we're actually delivering the best, the value and the best outcomes for them? And so this was the early stages of the development of what's now the Cystic Fibrosis Registry in the US, which is, as you all know, not thankfully affecting a significant portion of the population, but which through its efforts as being a national registry and pulling together all of the sites across the country that do treat people with cystic fibrosis, has actually been able to move the needle, as they say, significantly in terms of life expectancy. So just to share a picture of that, as I said before, if this child had been born 30, 40, 50 years ago, the picture would not have been nearly as positive, whereas now the people who are born with a cystic fibrosis diagnosis are expected to live into their 40s. And one of the things that I think that's interesting, and we'll come back to in a moment, is that, you know, this here is a very crude measure of an outcome that matters to patients. I would argue that it's actually something that a patient would have as an expected or a given, their survival. But what's interesting is that the registry itself has shifted and now has a large number of measures that go more into the quality of life that these patients have. And so, for example, on the questionnaires to cystic fibrosis patients today are questions such as, do you have goals of higher education? Do you have goals of establishing a family? Something that, again, 30, 40 years ago would have been unheard of. So with that as a starting point, I wanted to talk about a couple of things today. First of all, I've been asked to talk about why value-based healthcare now. What's the pressure? Why do we actually care now? What do we mean by value-based healthcare? Because there's probably not quite as many definitions as there are people in the room, but quite a few to be sure. Importantly, how is patient care actually improved by using the tools and moving more towards value-based healthcare? And then finally, leave some thoughts on, you know, where we can go next from here. So first of all, why value-based healthcare now? And I want to start with a couple of the key challenges that all of our healthcare systems, Canada, US, Spain, et cetera, are focusing on. And at the root of all of this, as we all know, is that healthcare spending is growing faster than GDP. I could have picked any number of countries other than the 6 that are on this slide here. But as you can see, that the healthcare spend line in all of these 6 and many other countries as well is growing faster than the GDP is growing. And that is in addition to the high and in some places increasing rate of GDP that we're spending on healthcare. It's just not allowing us to afford the innovations that are most meaningful and most helpful to patients because of a lot of the challenges that we're facing. In addition to simply the economics of the healthcare spend growing faster than the GDP, if you dig one layer below that, in fact, a lot of our challenges come from the fact that spending is wasted, unfortunately. This can be from inefficiencies of doing tests in multiple places because records don't travel with patients. It can be done by using devices and tests that actually don't have a positive proven impact on the outcomes itself. So I don't want to get into all the details on this slide, but one example to take the second line there, you can see there's something called these spacesuits. These are single-use suits which are worn by clinicians in an operating theater that have a cost on average of 400, 500 euros. That when tested in a couple of different hospital settings, were actually not shown to have a decrease in the infection rate for the patients where these were being used. So it's one example, but there are many out there that actually add cost to the overall treatment pathway, but actually don't have a positive impact for the outcome for the patient. But in fact, actually, for me, what must be the most critical of these three challenges is one that I view as being more silent or more hidden. And that is that there's significant outcome variation everywhere we look. So you can see a couple of examples on this page here, but if I were to look at it within a country, within a region, across countries, wherever we look at it, we see that in fact, the outcomes are hard to get your hands on, but then when you do get your hands on them, you can see that there's significant variation. So just to give an example here, 3 lines down, we see a 6x variation between those hospitals that have the best rates of readmission after hip surgery in the UK versus those that have the worst. Similarly, in Germany, we have a variation in reoperation rates after hip surgery of 18x. There are a lot of hospitals in Germany, but the 18x is a very, very significant, and I would almost say a hidden problem because we just don't have the transparency on these. When we do have transparency on outcomes, such as the case with the Cystic Fibrosis Registry or other similar registries or transparency efforts, we quickly see that clinicians are striving to be better. They strive to improve their care, they strive to improve the outcomes, and even without additional enablers such as changing the way that people are paid or incentivized, the transparency of the outcomes alone has a significant improvement effect. So those are some of the challenges that I particularly feel are relevant in terms of why value-based healthcare now. But let me step back again and say, what do we actually mean when we talk about value-based healthcare? And I want to take you through the definition that was developed over the past couple of years by a project run by the World Economic Forum. So BCG was the knowledge collaborator together with the forum, and we had leaders from the CEOs, for example, from Novartis, from Medtronic. We had the head of Kaiser Permanente in Intermountain. We had the head of NHS in England. We had the Minister of Health in the Netherlands, etc. And so at the end of the day, the definition that we came up with by default is actually very much a multi-stakeholder view of the system. It's all based around the patient at the center, though, the patient and the population. So that's why we start with this image here. And at the root of it, for those of you who may have read works by Michael Porter or others who have written about value-based healthcare, is very much this very simple equation of the patient outcomes, those outcomes that matter most to patients, over the cost to deliver those outcomes. And that in itself is called value. And so value can be improved either by improving the outcomes and or lowering the total cost to deliver those outcomes for a particular patient population. But that in and of itself is not necessarily the unit of analysis that we need to think about. We actually need to think about it on a population segment basis. And we use the word population as opposed to patient because we want to include preventive care as well. So not only once somebody has a diagnosis, but we also want to think about value-based healthcare as it applies to the adult healthy population or newborns in terms of prevention and vaccines. But more typically, it's used today, as you're well aware, with those patients who have one or more diagnoses. And so that's the unit of analyses that we're looking at, the outcomes that matter to those patients who fall into a similar patient population. It's also relevant to look at it in terms of the segment-specific interventions. So for a patient, for example, with prostate cancer, these segment-specific interventions could range from watchful waiting to a more proactive stance of surgery, drug treatment, etc. So its intent is to include all types of the interventions possible for the particular diagnosis and for the particular patient population. At the end of the day, it's a very data-driven approach. So we need data on the outcomes in order to be able to drive the best practices and the learnings. So it relies on developing informatics, health informatics, and one of the underlying pillars of that is interoperability, so that we can share data across our own local systems, but also then more broadly across systems, in order to use that data to do benchmarking, to figure out what the best practices are, to do further research on both drug development and treatment development, as well as new care pathways and decision support tools for clinicians. Now, there's an element obviously about delivering the care. What value-based healthcare is not about is, say, optimizing the number of primary care doctors or developing more tertiary centers. Instead, it has at its root, going back to the center of the diagram, the outcomes and the costs. And so it's about figuring out for the patient population at hand, what's the best way to organize care for them. Now, in some cases, that could be more home care, that could be more of telehealth consultations and the like. So it's really, again, operating around the core of this, which is the patient population. Obviously, payments and incentives are a critical part of this. Ideally, what we want to move away from is pure fee for service, because that has some disincentives and associated with it that don't allow us to move the value paradigm. But in fact, there are many different ways that we can incentivize and pay differently, as long as we're moving away from the disincentives associated with fee for service. And finally, this has to operate within a system that has policies and regulations which are both supportive, but also make sure that they do not prohibit the development of value-based healthcare. So I've hoped that that gives us a good starting point and a common definition across the stakeholders. Let me turn to what really is critical about this and what makes it different, say, from some of the other ways of thinking about healthcare transformation. And that, at the end of the day, really comes down to the outcome side of it. People have been looking at costs for decades, and unfortunately, we saw the graph before, it hasn't moved the needle. The costs are still growing faster than other elements like GDP. But it's really about the outcomes. That's something that we've seen increased focus in the last couple of years. And let me take a moment then to think about what outcomes are. When we define outcomes that matter to patients, it's sometimes easier to start with what we don't mean by outcomes. We do not mean that outcomes are the initial conditions. We do not mean that outcomes are the processes of care delivery. It also is not an outcome to think about the structure of your hospital certifications, your facility standards, and the like. And finally, there are a number of clinical indicators that some people may ascribe to be outcomes, such as in this case on this slide, we're seeing an example for a patient with prostate cancer. And those indicators would be things such as the PSA score, the Gleason score, the surgical margin. But in fact, those are not truly outcomes that matter to the patients. They're necessary things to measure so that we can identify the right treatment choices. But if we really focus on what are the outcomes that matter to patients, these are things in this particular example, again, being a patient with prostate cancer diagnosis, these are at the first level survival. Then they come to more specific outcomes such as continence, erectile function, and anxiety. Now, all of these outcome categories here are ones that have a cost to the healthcare system, and increasingly where we see them being measured and actively monitored, we see that not only do the outcomes improve, but the cost to deliver those outcomes actually is able to be controlled and come down overall. Now, we have a lot of different ways that we could talk about outcomes. There's an organization that many of you may have heard of called ICHOM, which stands for the International Consortium for Health Outcomes Measurement. Now, ICHOM is an independent, not-for-profit organization, which was co-founded by the three organizations on the left, BCG being one of them. And it's essentially set up with its mission to define a minimum standard set of outcomes by patient population. And so you can see on the right-hand side some of the examples of those sets which are already developed. There are now 28 sets on the website available for download. They're openly available. And those are tackling over 50% of the global disease burden in terms of spend. Now, the way that these sets are designed is by having the leading global experts clinically come together with patients or patient representatives through a process that's roughly around 6 months to build consensus. So they start by figuring out what are the main domains or the main types of outcomes that matter to us for this particular patient population. And then they go through a literature review of existing measures to figure out for each of those domains what would be the set of measures to recommend. And then you can see in the bottom corner there that each of those different color shades of green is one measure. So at the end of the day, we're not talking about hundreds or even tens of measures here, but we're talking about a fairly small number, with the goal being that these would be measures that are standardized. Any institution or any clinician can measure beyond this, and obviously will do so. But at least if we agree on these common minimal standards, then we can start to do some benchmarking and some comparison in a broader setting. So ICHOM started back in 2012, and it's as I said before, an open platform for people to go onto and look at. We know that there are at least 30 countries and over 650 organizations. I've actually heard more, like 1,000 organizations now using one or more of the ICHOM sets, but it's hard to know because, as I said, this is no fee or registration required to use them. Interestingly, it's also something that has been in collaboration with the OECD. You may have heard about this Paris program, which is about patient-reported information systems and outcomes. And so ICHOM is collaborating with OECD on that practice. Interestingly, also for the academics in the room, for the majority of the 28 sets, as soon as they are finalized, the working group for that particular set submits it for a peer-reviewed journal for that particular population. And so they are published shortly after being finalized. Let me then switch gears and talk briefly about, how is patient care actually improved with value-based healthcare when we see institutions implementing it. And let me choose an example, which are 7 Dutch hospitals. These are there's no common structure, ownership structure across these. There are 7 independent hospitals. As you can see, Netherlands is a fairly small country, but they're located in dispersed parts of the country. And what happened a couple of years ago was the CEOs got together and said, we want to pool our resources, and for ourselves and for our own hospitals, we want to start to understand what best practices are for particular patient populations, measure those outcomes, and compare our results. And so what they did was they looked at it a bit differently from historically in terms of, by department within a hospital. So typically you would have the head of cardiology, the head of internal medicine, et cetera. They still maintain that organizational structure, but what they did in this study was to actually look at it on a patient flow. So in other words, a breast cancer patient would touch many elements in the hospital, and they use that as a unit of analysis, so the patient population. And you can see here, breast cancer, prostate cancer, and cardiovascular are 3 of the first patient populations they've done. They've now increased significantly, and they have a group that's monitoring this and adding to it new patient populations every day. The process they went through was effectively, first of all, to establish a multidisciplinary team at each hospital, but also then a team across the 7 hospitals, define the scorecard and what they wanted to, in terms of what they wanted to measure. And then every 6 months, they would go through a process whereby within each hospital, they would collect the data, analyze it, and identify the best practices. And then across the 7 hospitals, do the same so that they could figure out and learn from each other. Again, Holland is a small country, but as you'll see in a moment, the differences were quite large. So let me spend a moment, first of all, just to talk about the team. So the multidisciplinary team they formed, you can see here on the slide, it's not rocket science. I mean, you would expect that if you were to gather the people who are treating breast cancer patients, these would be the roles that you would expect to see. But 2 things I think to note. One is that they did include the patients, which is not always the case. So I think that's a best practice that we've seen in other hospitals as well. And whenever they are included, it keeps everybody on the same page. It keeps everybody honest and brings a different perspective that's sometimes lacking, to be completely honest. But the other thing that was interesting is that even though these professionals all treat breast cancer patients, they hadn't necessarily even met within the same hospital. So in one case, we had a surgeon as well as a nurse in recovery who had both been working there for more than 10 years each at the same hospital, but had never met, even though they treated the same patients. So as soon as you start to bring people together around a patient population, as opposed to in their typical organizational structures, you start to see some different conversations taking place and some quick ideas in terms of improving both patient care and then thereafter having an impact on the outcomes. The other thing I just wanted to share was a simplified version of their scorecard. They didn't have more than 20 measures on this. I've just chosen a couple of here to highlight. But you can see that basically they fall into 3 main categories, with the 4th being the treatment mix. So outcomes is the starting point. And as I said before, that's mostly been what has been lacking in other healthcare transformation efforts. Some costs and some processes. Now, let me say a little bit about each of these in turn. On the outcome side, they started with patient populations that did indeed have ICHOM standard sets already published and available. And they looked at each of those sets and made a selection. So they very pragmatically said, look, there may be 12 items on the breast cancer set, but feasibly across all of our 7 hospitals, we can really only start by measuring 7 of those. So let's start with these 7 and see where we get to, with the goal of adding over time. And on all of the outcome measures for ICHOM, and what this group of hospitals also did, is you can see that the first one is an example of a clinical outcome, so something that the clinical staff would track and monitor their own progress on, as well as a patient-reported outcome. And here, some quality of life measures that came from the ICHOM standard set recommendations. Beyond outcomes, the costs you can see here are in fact not euros or not dollars, but instead, because of wanting to avoid any complications about different salary levels, different staffing levels, etc., uses of resources that would be something that's comparable across different hospital settings, different clinical settings. And so here you see 2 examples of some of the main cost drivers. And the processes were included, a couple of them. I think there were no more than 5 or 6 processes out of the overall 20 measures, roughly. And the reason for choosing these processes were because they were expected to be the root causes of some of the variation in either the outcome side or the variation on the cost side. And finally, although this was not something that they looked to do in a peer-reviewed journal on their first pass, but it was much more around a learning system, they did start to include more of treatment mix variables for risk adjustment. And even before they did significant risk adjustment, they already started to find meaningful differences, which they could have an impact on in a fairly short period of time. And so let me share with you briefly then some of the results that they were generating. This here you can see is the 7 different hospitals, their starting point on one of the metrics. This is for, again, the breast cancer example, and the particular measure here that we're looking at is the reoperation rate due to positive margins. In a small country such as the Netherlands, in these 7 hospitals, you already could see a 4x variation in this one metric, and that was similar across the other metrics they chose, and surprised them, to be completely honest. They were not expecting this level of variation among their 7 hospitals, and worked overtime to reduce that fairly quickly. So this was the starting point, as I mentioned. And then what they started to do is they started to have discussions around, well, how is it that you do your surgery? How do you define the right margin? What are the steps you take? And it came down to some best practices, such as those with the lowest rates actually used an echo during the surgery before the patient went to the recovery room, to make sure that they had indeed recovered or removed all of the tissue. And there are other examples like that. So once you have people reviewing the practice, seeing the results, seeing the outcomes, then you can quickly identify what the best practices are using a data-driven approach. So after, you can see here, this is cycle 1 and then cycle 3. As I mentioned before, a cycle is 6 months. So this was basically 12 to 18 months later. You can see that overall, there's a 17% positive improvement on the reduced reoperations from the positive margin. So that's the improvement overall. And you can see some of the those who had the outliers made indeed the biggest improvement rates. So I think it's a positive effect. And I think one of the things that's not captured in these numbers here, but when you talk to the people who are in the hospitals here, they are just thrilled with this approach. And in fact, the guy who runs the overall value-based healthcare across all the 7 hospitals has people knocking on his door saying they want to be the next group. It's changed the way that they cooperate. It's changed the way that they engage with patients. And it's obviously had a positive impact on the outcomes for those patients. And so in the interest of time, let me just make a couple of comments on where we might be able to go next and what are some of the things that we need to keep in mind as we move towards value-based healthcare transformation, and then open up for questions. It's not easy. Otherwise, I think everybody would be doing it so far. And we have gathered some learnings from where we've seen this being implemented in various places around the world. Some of the things that make transformational change with value-based healthcare hard are the fact, first of all, that there's actually no single one authority to mandate the change. In most cases, we're operating across different types of stakeholders, across different institutions, and none of those has necessarily the leadership to actually mandate the change. Secondly, there's a level of conflicting goals and incentives across the different stakeholders. I mean, historically, that's what's partially gotten us into this issue, where the goal of, say, very crudely to put it, say the goal of pharma and med tech is to play the volume game times the highest price they can, whereas for other industries it hasn't been the goal to have the patient at the center. The commitments to change are typically something that's hard to enforce and hard to keep momentum around over time. In addition, there's no shared culture. Each of us is used to working within our own organizations. We partner on various initiatives from time to time, but getting a common culture to drive change across these institutions makes it hard. And finally, even just the logistics. We don't all share, as is seen today, we don't all share the same AV platforms or the same calendars or the same ways of working. So those are other challenges. And so at the end of the day, there's challenges around authorizing the multi-stakeholder work. Who's the actual authority that should be driving this? And in fact, there actually is no one authority to be doing so. And then once an initiative is identified and starts moving forward, how can we actually maintain the momentum? And there are challenges around holding the people together to cooperate for the longer term. So what have we learned from this, and where have we seen some of the best practices, both at Santion but other places as well? And I think it all starts with a shared understanding of the problem. So spending enough time with sleeves rolled up, and as somebody once commented to me, eating bad sandwiches and cold pizza is one way to really get that common vision for change. A second element, I think, which is a hallmark of the successful initiatives, is having a broad network of champions. So, for example, it doesn't have to be the Minister of Health or the mayor of the city or the head of the hospital, but rather each of the participating institutions needs to have a series of champions to connect the institutions and create that web of champions. Then also, I think there's a lot about setting the right collaborative environment, giving permission to both test new things out, but also building on trust. Again, there's a lot of lack of trust in the healthcare industry, broadly speaking. And so this works well on a small scale, getting to know individuals and then working over time in a collaborative way and building up that trust. And then finally, we've seen, neutral full-time project management is one of the critical elements to this. And in fact, there's an initiative ongoing, which is a carryover from the World Economic Forum project a couple of years ago in Atlanta, where some of this project management is actually coming from a patient association. So the American Heart Association is actually providing some of that neutral full-time project management, well-respected and neutral versus some of the individual hospitals, the payer associations, and pharma and med tech. So let me conclude with this slide here, where, to me, value-based healthcare is really about working together. It's around not necessarily doing radically different things, other than starting to have different types of conversations, always keeping the patient and the patient population at the center and focusing most on the outcomes that matter to those patients. So the African proverb says, if you want to go fast, go alone, but if you want to go further, go together. And so I think this is very much, for me, what sums up the transformation, successful transformation around value-based healthcare. So let me pause here and open for questions.
So questions or comments, I'll figure out technically how we are conveying them to
Okay, somebody's
to
asking
Jennifer.
a question. I can't hear it.
Yeah, we might have to type them in. So let me just figure that out. But does anyone have any questions or comments?
Hi, Jennifer. It's Louise. I'm interested in how you include social determinants of health in your patient-reported outcome measures to make sure you hear from populations that often aren't heard from in terms of their values.
Okay, Louise, I understand, has asked a question. Interested in how we include social determinants of health in getting patient health in populations that are often not included. That's a great question. And I think that, in fact, if we start with the patient outcomes and, you can think that there are many patient populations that don't yet have proper outcome measures defined or tracked in a meaningful way. I think it's around starting with the most basic of those. So there's a common set of PROMS tools or patient-reported outcome measures that can start to get at some of the social determinants, but also populations that are often not included. And these are standard ones that are going across different patient populations, so it's not specific for a one diagnosis. But I think those are common ways of starting to get those marginalized populations included. And so essentially, I think one of the key elements of making that a success and bringing those in is finding a way to capture that data. And capturing that data can be done the old-fashioned way, which is some hospital organizations actually hire nurses to do outreach, telephone outreach, and conduct the PROM survey over the telephone, and they can therefore control the responses, make sure that they actually get the responses in, etc. And increasingly then on the other end of the spectrum, we see a lot of these patient-reported outcome tools being available on mobile apps, and something that is both prompted then from the patient on a regular basis with an easy to fill in set of questions on the app itself. I hope that answered the question. This is tough without any feedback.
One more simple question. No compound complex
I can hear.
sentences.
I can hear.
Oh, you can hear?
Yes.
Oh, good. Okay. 'cause I was like, I was trying to do it for typing. So with the Dutch study, with the 7 hospitals, I represent a patient organization, and we're very keen on this looking at outcomes between centers, let's say. How did you overcome the professional fear of comparison? Who drove, there had to be some leadership around overcoming the kind of fear of that professional comparison between surgeons in the case of the breast cancer example. I'm curious about how that was overcome.
That's a great question, and it's one that's always present when people start to do this. They always say, well, my patients are sicker, it's not a fair comparison, the data is wrong, etc. And so I think there are a couple of elements which contributed. First of all, it was a time that was dedicated upfront to gathering and cleaning the data, where people had visibility and buy-in, both to the measures that would be used, but also then to see the data itself and understand that, yes, these are my patients, these are my results, and be comfortable with that before they were actually shared with any of the other institutions. So in fact, there was sort of a process of gathering the data and cleaning it, and then having blinded results, and then eventually you could see where you were, but not who the others were, to get to the stage of you could see where you were and you could see who the others were in terms of the best practices. The hospital CEOs themselves, in this case, actually drove a lot of the leadership. It was their decisions, and it took quite some time. It took probably over a year before they got to this level of wanting to do it, and all were comfortable with the approach, etc. So that is an upfront investment of time to make that happen. But then I think another key element was just making sure that the populations that they chose as the first couple of pilots that they looked at, breast cancer being among them, had a strong clinical champion. So they had a clinical leader at each of the hospitals who was very committed to this, who believed in the approach, and was willing to take on the challenges associated with seeing the data in a different way and getting to comfort level with that. So I think those are a couple of the contributing factors in terms of getting the leadership right and getting the clinicians engaged.
Thank you. Anyone else? Was there one more? No? Yeah. Yeah. Here we go.
Thanks. I just wanted to come back to the issue of no single authority, like that problem of who's driving this, and wondering what maybe ICHOM is doing to push out all of these results in a way that there's way more encouragement for uptake in terms of wherever the institutions are across all of these different countries.
That's a great question. So, ICHOM, as I mentioned before, is an independent, not-for-profit. They're fairly small scale still, to be completely honest, but they have amazing impact. So, one of the things that they're trying to do is to do some structured benchmarking. The first step to that, they actually are working with some data scientists to transform their list of outcome measures, which we saw those little green segments of each of the wheels, to be more machine readable. And so this is a process where the work was presented just 2 weeks ago at a World Economic Forum summit meeting in Rotterdam in the Netherlands, and 4 of the 28 sets have now been both standardized and made machine readable. So that's one of the steps, I think, in terms of driving this forward, is making the ICHOM standard sets not just a concept that exists on paper for everyone to access, but rather actually something that you can sort of plug and play, if you will. Because I think the more user-friendly we can make the outcome measures themselves, that will help drive the uptake significantly. So in addition to ICHOM, and there's many initiatives, and I'm sure I'm not going to mention all of them, but the World Economic Forum, as I mentioned before, had the multiple year project. The conclusion of that in January of this year was the launch of the Global Coalition for Value in Healthcare. So the World Economic Forum is hosting this. There's actually, many of you in the room may know, ValueBased Healthcare Canada, as a new multi-stakeholder public-private partnership, is one of the first members of that global coalition, with the overlying goal that they will bring together similar types of coalitions who are working on the value-based healthcare enablers, be it defining and measuring the outcomes, or be it payment reform along value-based guidelines, working on the informatics piece, etc. So those are a couple of things that are trying to drive the uptake of value-based healthcare more broadly.